cardiovascular aspects. And what I'm now going to do is to show you how we apply comprehensive geriatric assessment in the field of assessing appropriateness of prescribing in older people, and more in particular prescribing of cardiovascular drugs. Just as an example, because the session is devoted to cardiovascular aspects. These things are very well known, but still the numbers are very impressive, and I would like to keep your attention just for a second on several of these numbers. So by the year 2050 in Europe, the number of citizens older than 65 years will be higher than those younger than 10 years. So Europe is getting older. It's the fact. And 60% of older people have 2 or more apparently unrelated diseases. So the problem of comorbidity and multimorbidity is also emerging. And why is that important to know? Because multimorbidity is inevitably associated with polypharmacy. If we have a patient with 2, 3 or more chronic diseases, in many instances the patient would need 2, 3 or more drugs to treat each of those diseases. Why is the multimorbidity so important? Because there is clear evidence that multimorbidity increases mortality, increases healthcare utilization, increases hospital admissions, and also, on the other side, decreases quality of life. And what we have of this slide is a very important to remember. So far, the existing evidence with regard to certain entities, to certain diseases, is single disease oriented. We don't have any really reliable guidelines in the literature related to an older patients with multimorbidity. We have guidelines with regard to hypertension, to diabetes, COPD, and so on, but there are no guidelines addressing all different combinations at the same time. So the term geriatric syndromes is important when we speak about older people. A distinction is necessary between older people who are very well functioning and those who are disabled or frail. And among those who are frail, we are confronted with so-called geriatric syndromes. And what you see that even in the context of geriatric syndromes, different combinations are possible, like falls, incontinence, functional dependence can take place in the same patient. And also, dependence in different aspects of care can be present, like physical performance, sensory impairment, and or affective impairment. So you see some additional numbers from the literature illustrating that also the bulk of cardiovascular diseases is very important among multimorbidity and among these geriatric syndromes, patients with frailty profile. So you see that with regard to systolic hypertension, with regard to heart failure, with regard to syncopes and falls and atrial fibrillation, there is a great impact of these diseases on the functioning and the quality of life and survival of older patients in general. As we have a look as a kind of a mirror side at the medication list necessary for all these conditions, then we see that also the impact of and the percentage of cardiovascular drugs is also very, very important. And there are 2 classes, to say so, which deserve our attention when we speak about disabled or frail people in terms of pharmacotherapy: cardiovascular drug classes and psychotropic drug classes, generally spoken. this is one part of the medal, to say so. The other part of the medal is almost absolute lack of the evidence with regard to these geriatric syndromes, with regard to older people with multimorbidity, and in particular also older people with multiple cardiovascular diseases. So you see studies involving geriatric patients, only a little bit more than 3% randomized controlled studies, and only 1% of meta-analysis. It is not comparable with the impact of these diseases that we see in our older population. Knowing that in the real life, the majority of the patients we are confronted with will have at least one cardiovascular problem, while the study population representing these diseases is somewhere between 2 and 9%. So, as I already pointed out, it is impossible to address these patients in a really evidence-based way. So you have to be pragmatic as it comes on the assessment of pharmacotherapy. And what are we with other colleagues interested in the topic, proposing and trying to gather evidence about is a kind of systematic stepped approach, multi-step approach. So where the first place should always be, as I pointed out in the previous presentation, screening, identification of subjects at risk of drug-related problems and adverse drug reactions. The second step, logical step, is once we identify the people under higher risk, to go in depth and analyze their medication list, so to perform a medication review. And then the next step, once we know which medication the people really take, to go into depth with regard to analysis, are the drugs the people are taking appropriate or are they less appropriate? We can rely thereby on some I would say, additional assistance in terms of computer-based prescribing systems. But here again, I'm stressing very importantly that all should be a part of comprehensive geriatric assessment. So the assessment of pharmacotherapy is only one part of the global assessment of the patient. With regard to that medication review, which is also a very important step in the assessment of pharmacotherapy, there are 3 points. The first point is always identification of all drugs that patient is really taking. And you have to ask that not only to the patient, but very frequently to family members, general practitioners. You have to reconciliate the drug list that the patient is really taking at the very moment. The second step is screening for potential drug-related problems, thereby using validated instruments, and I'm going to address one of those in a moment. And the third step, again, you see the formula has been repeated, which I proposed in the previous presentation. Solution, how to solve problems that we have identified in the previous step. It is important to know which instruments we can use in order to assess the appropriateness of the prescribing. And briefly spoken, there are 2 groups, so-called explicit instruments that each and every caregiver can apply and can use in their practice, because these are mostly lists of drugs or diseases which deserve attention with regard to pharmacotherapy. And the second group are implicit instruments. They deserve, I would say, they deserve more in-depth knowledge with regard to pharmacotherapy, and they are based on a more broader interpretation besides only pharmacotherapy. One of these explicit instruments or tools are so-called stop-start criteria, which were introduced by our colleagues from the University of Cork in Ireland, the group of Dennis O'Mahony in 2008. And you see, there are very well organized lists of conditions. I'm taking here a detail of cardiovascular system. So all the lists are organized based on physiological systems. And if you have a look, the text is small, but for example, you have a very concrete examples. What you have to consider stopping is, for example, loop diuretic as a first-line monotherapy for hypertension. So you have analyzed the list of your drug list of your patient. You have found that the patient is receiving a loop diuretic. He has also hypertension. So the loop diuretic should not be the first choice for hypertension. Then, for example, combinations of certain drugs, combination of a beta blocker in combination with verapamil, old calcium channel blocker, is also not advisable. So you see, it is very easy to apply. Everyone who can read can apply this in his practice, but the message behind this is a very important one, that you have to interpret this in the broader context of the patient's condition. As I told you a moment ago, there are different physiological systems, but here we are focusing now on cardiovascular drugs. The first version of these stop-start criteria had 65 rules as stop criteria, so alerting people to stop these drugs, and 22 rules of drugs that could be recommended. For example, warfarin in the presence of chronic atrial fibrillation, unless, of course, the patient is under the risk from other points of view. So you see, there are very pertinent and very easy to apply recommendations. In the meantime, the second version appeared in 2015 with more criteria, 80 stop criteria and 34 start criteria. Just to give you an example, again, organized in the same way. You cannot read the text, neither me, but on the screen, but the system of organizing these criteria is the same. In the meantime, because I told you in the beginning, the evidence with regard to this topic is lacking, but in the meantime, the evidence has been improved and is still emerging with regards to start criteria, and even in the UK, stop-start criteria have been endorsed as best practice guidelines for the management of frailty or pharmacotherapy aspects in frail people. The evidence is gathering there, and also our society, UGMS, has endorsed these criteria as an appropriate way to assess pharmacotherapy in older people. So you see that there are also some other advantages of this evidence, that average number of drugs prescribed is significantly lower, with also impact on potential drug-related problems, adverse drug reactions and drug-drug interactions. Also, not to be forgotten, average drug cost significantly decreases, and also a clinically important outcome, average number of falls significantly reduces. Because in terms of falls, two drug classes with the highest risk are, of course, cardiovascular drugs and central nervous system drugs. And it has been proven that by applying these stop-start criteria in a thoughtful way, we can even have improvement in terms of clinical outcomes. Just to tell you how we proceed further with this topic, we are now almost in the latest phase of the European project called Senator, in which 6 European centers took place, our center included, and in which we developed a software as an assistive tool meant to be applied by non-geriatricians, and among them also cardiologists and cardiovascular medicine specialists, to use this tool in order to assist them to improve the appropriateness of the prescribing in their older patients. So what is the advantage, potential advantage of this concept? The final results still have to be analyzed and published, is that the software is gathering different aspects of the medical file of the individual patients, of course, medications list included, and provides an advice, a simple advice in several sentences to a treating physician who is not a geriatrician. And one of the research questions was to compare that approach with an approach of comprehensive geriatric assessment in the hands of geriatrician as a golden standard. Why? Because comprehensive geriatric assessment has already proved that it can be very useful in reducing drug-related problems in older people. And what is the principle? That the same assessment needs to consider the many factors that can influence a drug effectiveness beyond the narrow efficacy in that patient. So you have to take all the conditions, comorbidity included, polypharmacy included, to decide whether a certain drug is really useful and recommended in the very individual patient. So in older patients, these factors could include cognitive and functional impairment. And to come back to one of the questions of the previous session, if the patient has, for example, a very severe dementia, the approach would be completely different than in a patient who is cognitively independent, who is physically in a better condition, and so forth. So that will be my last slide. So in order to summarize, a stepped approach, a multi-step approach from screening to assessment is necessary. And if we speak about cardiovascular drugs, we have to remember that cardiovascular drugs take really a big part of the polypharmacy in geriatric patients due to high prevalence of cardiovascular diseases, of course, and that I would say a thoughtful approach and assessment of these drugs and conditions is necessary really to tailor the treatment to every individual older patient. And I will stop here. Thank you.